Imagine, if you will, a scenario that takes place in a women's health clinic, where a young woman of 23 years arrives for her first prenatal appointment at 24 weeks. She recently moved from Switzerland with her husband, who serves in the Air Force. She is a G2P1 with a BMI of 24 and states that she did not have any complications with her first pregnancy. She also had an uncomplicated delivery, and her baby weighed 6 pounds, 3 ounces. When discussing the diagnostic testing usually ordered for gestational diabetes, she became upset. She stated that she remembered the testing with her first pregnancy was very time-consuming, and glucose loading caused her to vomit and feel ill for the rest of the day. She then stated, "Since I did not have any problems with my first pregnancy, and no one in my family has ever been diagnosed with diabetes, do I really have to drink that awful liquid and sit in a lab for the entire morning? Isn't there some other way you can check to see if I have gestational diabetes?" Ma'am, welcome to the diagnosis zone.
Well, Krista, we can't make you do any testing that you don't want to consent to, but you should know that it's our standard protocol to test all women between 24 and 28 weeks for gestational diabetes.
So why is everyone screened?
Screening and diagnostic testing for diabetes are performed because identifying pregnant women with diabetes lowers the morbidity rate for moms and babies. We worry about macrosomia, shoulder dystocia, neonatal hyperglycemia, and even preeclampsia. So we like to know about those things before we get to delivery.
Okay, so I see that there's risk factors for mom and baby, but is it really that common that you have to test everyone?
The prevalence is actually 6 to 7%, and that varies based on race and testing methods, age, and BMI. But in general, we're seeing an increase over time, and that's particularly parallel to type 2 diabetes.
Okay, well that's a lot more common than I thought. However, since I did not have any of those problems with my first pregnancy, doesn't it mean that I'll just be fine with this pregnancy?
Having a normal first pregnancy does put you at lower risk. However, each pregnancy is different, and it doesn't mean that you won't get gestational diabetes with this pregnancy. There are also long-term complications for you of having gestational diabetes.
Really? Like what?
Long-term women with gestational diabetes are at increased risk of developing type 2 diabetes as well as type 1 diabetes and heart disease, and their offspring are at risk of developing obesity and metabolic syndrome.
Wow, that all sounds really scary. I really don't want to be that difficult patient, and I want the best for my baby. But just the thought of drinking that sugary drink makes my stomach turn. Are you sure there isn't something else we can do to make sure I do not have diabetes?
You know what, give me a moment. Let me go talk to my attending about our protocol. I'm going to step out for a minute if you don't mind, okay?
Sure.
Oh, come in.
Dr. Ike, hey, do you have a minute for me to run a clinical question by you?
Hey, Amanda. Yeah, sure.
Do you mind if I sit?
No, go right ahead.
Thanks, sir.
Yeah.
So I've got this patient. She's 23-year-old. She's here for her first prenatal visit. She's 24 weeks. She does not want to do the standard glucose tolerance test. What do you think I should do in this type of scenario?
Well, every case is different. Tell me a little bit more about her.
Well, she's Caucasian from Switzerland. She's a G2P1. She's got a BMI of 24 and no history of gestational diabetes with her first pregnancy.
Sounds good so far. Any family history of diabetes?
Nope.
Any complications with her first delivery?
Nope. She had a normal, uncomplicated vaginal delivery.
How much did her first baby weigh?
6 pounds, 3 ounces.
Is her weight gain within normal limits for this pregnancy?
Right on track with a fundal height of 24 centimeters.
Oh. Okay. Well, she certainly does sound like she's at low risk for gestational diabetes. I'm sure you recall pregnant women with certain characteristics are at increased risk of developing gestational diabetes, and the risk increases when multiple risk factors are present. Take a look at these figures.
stimulating. I actually do recall those risk factors as I graduated from one of the best programs in the country. Dr. Ike, thanks. What do you suggest I do with this situation?
Well, recently I read a study that I think may help us out with this scenario. The recommendations included a simplification of our current standard by not performing the glucose loading in women with fasting glycemia of less than 4.4 millimoles per liter, or those greater than 5.1.
That sounds good, but are you sure that this study is applicable to my current patient?
Well, it's very applicable. In Switzerland, the population is primarily Caucasian, and the prevalence of gestational diabetes is low.
Wow, that is a coincidence considering she just relocated from Switzerland with her husband who's in the Air Force.
So it's even more applicable than I expected.
Dr. Ike, you're so smart. I have another question. You said that the prevalence is low in Switzerland. Does that affect the findings?
Well, yes, it can. In addition to the study discussing its findings as compared to previous studies, the authors acknowledge that in lower risk populations, this screening method is less sensitive. This lower sensitivity can result in more people who actually have gestational diabetes to be labeled as not having gestational diabetes.
That's not good.
Well, it does make it less sensitive, but the findings still appear to be clinically relevant.
Okay, so what do the researchers propose for diagnosing GDM?
Well, the study proposes that instead of every patient undergoing glucose loading, which is the gold standard, only those with a fasting glucose ranging from 4.4 to 5.1 should complete the test. Anyone under 4.4 should automatically be labeled as not having gestational diabetes, and anyone over 5.1 would automatically be labeled as having gestational diabetes.
So what you're saying is they propose that we only do glucose tolerance testing on patients with diabetes, with finger sticks between 4.4 and 5.1?
Yes.
Okay. So how many of the patients fell between 4.4 and 5.1 in the study you're referencing?
Good question. There were 2,298 pregnant women in this particular study, and using those parameters, roughly 70% of the population studied, or 1,586 women, avoided glucose loading.
That's a lot of people not tested. That sure would make my patient happy if her fasting levels were outside that range, since she wouldn't have to drink the glucola.
I'm sure it would. That is precisely why I mentioned this study.
But won't that increase the number of patients we will incorrectly diagnose with GDM, as well as increase the number of those we may miss who actually have GDM?
Yeah, but because no testing is 100% accurate, there's always a chance that a patient can be incorrectly labeled as gestational diabetic or not receive the diagnosis when they do indeed have a problem. The sensitivity of a test wherein the fasting glucose parameter is set at 5.1 is 47.4%. The sensitivity of a test wherein the fasting glucose parameter is set at 4.4 is 78.5%. And then the sensitivity increases to 96% when the parameter is lowered to 4.0, meaning 241 of those 251 people with gestational diabetes would be identified. Accordingly, sensitivity may continue to rise in populations that have higher prevalence of gestational diabetes.
And what about the specificity?
Well, the specificity at 4.0 is 25.3%, and the specificity at 5.1 is 100%.
So is there value in using this method for a GDM diagnosis?
Well, yeah, because regardless of the parameters, inevitably the outcome will result in less than 100% of women having to undergo glucose loading, which would save time, money, and likely increase patient satisfaction for those women. And I know how you like to make your women happy. But as mentioned before, it is important to remember that with a sensitivity score, if less than 100%, there's always the potential to miss patients with gestational diabetes.
I understand that, but it wouldn't be that many, right?
Well, sure, but when you consider the potential outcomes of missing a gestational diabetic as compared to the impact of the tests in terms of cost, time, patient discomfort, the number of women missed seems much worse.
Now you're just sounding like my DMP instructors going around in circles. What do you want me to tell this patient?
Well, for this patient, I would start with the fasting blood glucose, which is the starting point for the gold standard anyway. She may rule in or rule out with that one result alone and thus avoid glucose loading. So do you think you could get her to agree to just doing a fasting glucose?
She's not adverse to having labs drawn. She just doesn't want to drink the glucola. But what if her glucose is between 4.4 and 5.1?
Well, there are no negative implications of managing her as a gestational diabetic, especially if she controls blood glucose with diet and exercise. So that is a potential option.
Well, there are negative implications for her. I mean, she'd have to do a finger stick every morning, and she's got a child, so I'm just wondering also, what do we actually gain from that information?
Well, hopefully with her finger sticks, she'll either rule in or rule out. But if she's in the range we talked about, we need to discuss glucose tolerance testing.
But the sensitivity of the glucose tolerance test is only 76%. And her pretest likelihood of not having gestational diabetes is 90%.
Well, I understand that, but these are the protocols.
So what you're telling me, Dr. Ike, is that I went to 3 years of school to become a DNP nurse so that I could follow protocols. Thanks. Okay. Hey, Krista, it's Dr. Nacolette. So I did make some headway with the attending. You know, we talked about earlier, the protocol is to have glucose tolerance testing done on every patient. But Dr. Ike is suggesting that we just start with a fasting blood glucose, so it would be a finger stick. And with that, hopefully you'll rule in or out, although this is not definitive.
Well, that's kind of confusing. So we're going to test, but the test isn't definitive?
Right, right. What I'm hoping is that you'll either be above 5.1 and be labeled a gestational diabetic, or below 4.4 and labeled not a gestational diabetic. But if you're in the range between 4.4 and 5.1, we'll either have to talk about glucose tolerance testing, which is the glucola that you hate, or other ways that we could potentially manage your pregnancy as if you were a gestational diabetic. Mostly with diet and exercise. So let's just start with the finger stick, get those results, and then we'll go from there, and we'll have to talk more once we know what they are.
Why don't you take a look at this bullet point list?
Thanks, Dr. Ike. I do recall the risk factors as I attended one of the best universities in the country for midwifery and earned a DNP.
I'm so sorry. You're going to keep talking to him when he's laughing?
I guess.
About his bullet points?
Set at 5.1 is 47.44.
Wow, Dr. Ike, you're so smart. Try again, Dr. Ike. How many of those patients in the study fell between 4.4 and 5.1? I don't know when it happened.
The chill out.
And what about the specificity?
The specificity is at 4.0.
Did I say it wrong? Did I say it wrong? Specificity? Specificity?
Specificity.
I fucking said it like that.
You better rhyme not me too much.
And what about the specificity? And how about the specificity? I don't know how to say it without making you laugh. I really don't. Every time I say it, you laugh.
So you're telling me there's a chance?
I'm sorry. Stop asking me fucking questions. Go to the fucking lab.